when we have new entrants, because we have a lot of new entrants that I see in my TB clinic that have come into the country. So this would be an opportunity to ask them about vaccination and to make sure that they are vaccinated, and ask who is in the household as well to make sure that they do receive that letter for vaccination. So I just wanted to talk a little bit about the MMR vaccine. And while we're all here, I'm just going to diverge a little bit. And because I do allergy clinics, so I wanted to talk about first MMR vaccine and egg allergy. So there is no contraindication to have your MMR vaccine if you have egg allergy, regardless of the severity of the egg allergy. Even if you've had an EpiPen, even if you have an anaphylaxis to egg, you can have your MMR vaccine in the community. MMR does not contain any egg component. It's made on the yolk, it's made on the chick embryo, so it does not have egg, and you can have the vaccine in the community even if you have egg allergy. So measles vaccine itself was first introduced into England in 1968. Then the MMR vaccine was introduced in 1988. Then the two-dose schedule was then introduced in 1996. It's a live attenuated vaccine. It includes measles, mumps, and rubella, as we all know. The first dose of the vaccine is usually given at 1 year of age as per the national schedule. Then the second dose is given at about 3 years of age when they're starting preschool. So the measles vaccine is very effective in preventing measles. Once you get 1 dose of the MMR vaccine, you have approximately 93% effectiveness in preventing measles. And by the time you get the second dose of the MMR vaccine, it's 97% effective in preventing measles. As you know, when you get a vaccine, you mount an immune response and you have seroconversion, so you develop antibodies to that, to the measles. So almost everyone who does not respond, who does not have seroconversion to measles vaccine in the first dose of the MMR vaccine at the age of 12 months will then receive the second dose, and they will respond to the second dose. Therefore, the second dose of the MMR vaccine is administered to address primary vaccine failure. So this is just a chart that shows you, telling you about seroconversion after you've had the first dose, about the vaccine effectiveness and the duration of immunity. So just looking at measles rather than the rubella and mumps. When you get that first dose of the MMR vaccine, 96% of people will mount an immune response to it. So they will have seroconversion. After the first dose, like I mentioned, it is 93% effective in preventing measles infection. And after the second dose, it is 97% effective in preventing measles infection. And what about the duration of immunity? When you get the first dose and you mount a reasonable immune response to it, you should have immunity for at least 7 years. And after the second dose, you should have immunity for at least 15 years. You can have incidents where you have vaccine failure, although it is very rare. There's 2 types of vaccine failure. It can be a primary vaccine failure where you do not mount an immune response. But then, like I mentioned, you have the second vaccine at 3 years old, and most people will then mount an immune response. You can have a secondary vaccine failure where you initially mounted an immune response to the vaccine, but then these immune response wanes over time. So that's why you do have a very, very small proportion of individuals who will get infected despite vaccination. But then that's why we have the National Vaccination Program and the targets to try to get 95% of the people vaccinated, so that even if these people do get infected, we do not have these outbreaks that we are seeing now. What is a complication of MMR vaccine? It's very mild. We can have a rash, we can have fever, a bit of a headache. So we can get a rash-like illness 10 to 12 days post the MMR vaccine, where you have a mild fever, you have a blanching maculopapular rash, and you're not infectious, although the measles virus can be detected in oral fluid. So next, let's talk about the measles virus itself briefly. It is an RNA virus. It is a single-stranded virus. It has the genus morbillivirus and the family difficult to pronounce, but it's there. Like I mentioned before, humans are the only reservoir of this virus, and it is vaccine preventable. So that means that it can be eradicated with good vaccine coverage, like, for example, smallpox. The entire measles virus genome has been sequenced. That means that they were able to identify all the different lineages of the wild virus and the different geographical distribution, which is important in being able to identify where an outbreak started. They
just lost your audio there, Zainab. Don't know why it's not got the mute. To try Christina's laptop instead.
Okay. Can you hear me now?
Yeah, I can hear you now.
That's when then I can hear myself.
Can you turn your sound, the sound of your computer? And mute.
How do I do that?
From current slide, so second on the left. And click.
Okay. Can you hear me now?
Yeah, that's great. Thanks.
Yeah. Okay. So there have been global measles control measures. There were initially 24 different genotypes of measles, but as of 2021, due to the vaccine global vaccination program, there are only 3 genotypes.
Sorry, Zainab, it's a bit quiet now. Maybe do you and Christina need to switch seats? Are you a bit far from her laptop?
What were you saying, Kirsty? Sorry.
Just Zainab sounds a bit distant now because the audio is coming from your laptop.
To your computer instead.
Don't know why that happened.
Okay, so I mentioned initially that measles is very infectious. So it's a very highly infectious virus. And following exposure, 90% of susceptible individuals will develop measles. And when I mention susceptible individuals, so individuals that do not have vaccine, that do not have antibodies against measles, so unvaccinated individuals. The basic reproduction number is 15 to 20. So in a susceptible population, that means that one person can infect about 15 to 20 people. So that means that it's really important that when you see these patients in surgery, they're identified, and we try to do contact tracing in order to halt the spread of this infection. How is measles transmitted? So most of the time it's airborne transmission. You don't have to be face to face to actually get a measles infection. So if you stay with a person that has measles in an enclosed room for at least 15 minutes, you have a high chance of getting infected. So that's thinking about your triage areas in the GP surgery and triaging these patients before they come through and making sure that the clerk is aware or the receptionist is aware, so that these patients are not put in the triage area with everybody else. They're taken directly into the consultation room or put in an isolation room. So the spread is mostly airborne, it's droplet spread. But you can also have direct contact. So if you have direct contact with respiratory secretions, nasal or throat secretions, it can be spread that way. And very rarely it can be spread by fomites. So if you have articles that are soiled with nasal or throat secretion and somebody else touches it, then it can be spread that way. It's also important to know that these airborne particles will remain in the air for up to 2 hours after the person has left as well. So not to let anybody else into that room in that time. How does measles present? So measles presents as...
There's absolutely no way we can manage that in general practice of not being allowed into a room for 2 hours afterwards. I mean, I work at the Peds Hub, that just does not, that's impractical. I mean, so the best we can do is wipe down with alcohol wipes like COVID.
Yeah.
And that's, Kirsty's a better suggestion.
No, well, no, often you can't even open a window, can you, in clinical rooms? I mean, when in the sort of peak of COVID, a lot of practices had a sort of red room that we just saw, you know, if we had to see someone with suspected COVID face to face, we saw them in that room. But even then, we couldn't, if we're seeing lots of febrile children with urti and conjunctivitis, probably we can't leave a room out of use for 2 hours, can we? Between, I guess we just have to do the best we can do. And if you can assign, or if you've got enough rooms to assign a room as the kind of red room, and ideally that would be a room that you can ventilate, I suppose, open windows. But yeah, I think we just have to do the best we can do with what we've got. What do you do in hospital, Zainab? Sorry, do you know what they're doing on the acute peds ward?
Yes, we try to bring the patient directly into an assessment room to assess them in. If we think that they have measles, we ideally put them in our negative pressure room. But that assessment room is cleaned and wiped afterwards. But I don't think that we wait up to 2 hours, because sometimes we do need that room. So we wipe it down and we clean it, but we don't always wait up to 2 hours because it's busy. And it's just to be aware as well that because it's airborne, if you do have a case of suspected measles, the patient themselves can wear a mask, but we should be wearing FFP masks to filter these particles. So
is that an FFP3 mask, Zainab?
Yes.
It's recommended, yeah. So they're supposed to be fitted, aren't they? It's supposed to be fitted to your face.
They're supposed to be fitted. So I don't know about in GP practice, but in hospital, we always go and make sure we get refitted and tested.
Yeah, we never even got them during COVID in our practice. I don't know.
Okay, so classical syndromes. How does measles present? You can have the classical measles infection, which is a primary measles infection. This is the classical measles infection, is the infection that you see in individuals who are immunocompetent. And I'll talk more about that later. It can also present as a modified measles infection or breakthrough measles, where you have reinfection. So modified measles infection is the infection that you would see in those people who have measles antibodies, but the measles antibodies are not protective. And we'll talk a little bit more of that later. I've put this in very small letters. It's atypical measles infection. Atypical measles infection is not something that we should see anymore. They used to see it when people were vaccinated with the killed measles virus. So it would present with very atypical rash, very severe symptoms. It was not really infectious, but I'm not going to talk about it because it's not something we should see as we're giving the live attenuated vaccine. The neurological syndromes following measles infection is really important because, the patients may call the GP surgery back or come back with these syndromes, and it's important to be aware that of what they are in order to be able to refer them to a hospital, for example, or mention that as some of the red flags to the patients before you discharge them. Severe measles infection is usually found in extreme of ages, so very young patients, very old patients, or immunocompromised patients. And then also we have the complications of measles. So I will start first with talking about the signs of the classical measles infection. So classical measles infection, classically, we have clinical stages. We have the incubation stage, prodrome, exanthem is when we have the rash, and then we have recovery and immunity. So what things should we be looking out for? Incubation stage basically means that I've been infected with this virus. It goes to my mucosa, so my oral mucosa, to my throat, or to my conjunctiva. And when you get infected with the virus, what it does first is replicate. So the virus replicates in those sites. Then it goes to your local lymph nodes. Then you have your first viremia, where the virus goes into your bloodstream and goes to other reticuloendothelial cells. So this is all happening in the incubation period, multiplication of the virus and spreading of the virus. Incubation period is from anywhere from 7 days when you come in contact with an infectious person. And I'll keep saying this. An infectious person is infectious 4 days before the rash and 4 days after the rash appears. So incubation period starts when you come in contact with an infected person. It can be from 7 days to 21 days, but the average incubation period is 14 days. So after you've had that initial viremia, and the virus is now in your reticuloendothelial system, you have a second viremia, virus going back into the bloodstream, and this coincides with the clinical symptoms of measles. and this is your prodromal stage, your prodrome. In the prodromal stage is when we then have symptoms. So what symptoms do we have? We have fever, and the fever is usually, it starts off a bit mild, but it quickly becomes very high temperatures, going up to 40 degrees. So that will help you differentiate it from other common viral respiratory tract illness that children come with, that they have very high fever. Other symptoms that you have with is the same as other respiratory tract infections. So for example, you have malaise, fatigue, anorexia, tiredness. Then you have the 3 C's. You have the coryza, conjunctivitis, and cough. The conjunctivitis, everything starts off mild and they gradually intensify. So the conjunctivitis is, might then proceed to lacrimation and photophobia. The lacrimation is clear, watery. So it's a non-purulent conjunctivitis that we see in measles. And then we have the cough, and the cough can persist 2 weeks after the child gets better in other ways. Well, during this prodrome stage, we have an ANNP. So the ANNP is when we have the Koplik spots. So it says that the Koplik spots are not pathognomic for measles, but they do help with the clinical diagnosis of measles if they are present. So if you look at this picture, you can see about 1 to 2 to 3 millimeters white nodules on an erythematous background. They usually are opposite to your molar teeth, but they can be all over the buccal mucosa, and they can also go to the labial mucosa as well. They last for anywhere between 12 to 72 hours, then they start to sludge off. And by the time the exanthem comes, then the ANNP, which is the Koplik spots, have already begun to disappear. So then the exanthem comes, which is your classical rash. The rash for measles usually starts in the face and behind the ears and spreads downwards. So we say it's cephalocaudal in its distribution, from the head spreading downwards. Then it spreads from the trunk to the periphery. So we say, so from inwards outwards as well. The rash, it's initially an erythematous maculopapular rash that is blanching. As the disease severity increases, the rash becomes more and it can coalesce. I'll show you a picture of the rash soon. The rash can coalesce. So the more severe, the more intense the rash is in a child, the more severe the illness is in measles. The rash can actually have some petachia as well, and it can be a hemorrhagic rash. It will last for about 2 to 4 days. By the time you get into the 3rd and 4th day of the rash, your fever should start to decrease as well. And this is important to know. So if a patient calls or comes to the GP surgery, we're in the 3rd day of the rash, and we're still having 40-degree temperature, then at this point, you should be thinking, are we dealing with a complication of measles? And we'll discuss about the complications. So then we have the recovery period. In the recovery period, in a Caucasian, the rash starts to change color and becomes brownish in color, and then gradually starts to fade and desquamates. But in a person of African descent, obviously, it was always brownish color, but it can desquamate in some areas. Once you've got measles infection, you should be immune to get measles infection again, although there have been rare cases of repeated measles infection. And also, measles actually has an impact on your immunity, which we'll talk about later as part of the complications. This is just a study in PubMed about the predictive power of Koplik spots for the diagnosis of measles. Koplik spots were highly predictive of confirmed measles and could be a good clinical tool to enable prompt measles management and control measures, because these Koplik spots come out before the rash. So if you have a good look in a patient that's coming in with the fever, coryza, cough, conjunctivitis, and you have a good look and you see Koplik spots in the buccal mucosa, this might alert you to this might be measles. Then we can start control measures, identifying who else is in the household. Is this a at-risk patient? Do they need to come to hospital for immunoglobulin, etc.? So again, this is a Koplik spot. It has been described as a grain of sand on a red background. And this is a classical measles exanthem. This is in the trunk. You have your blanching erythematous maculopapular rash, and you can see that in some areas they're beginning to coalesce. And like I said, in children, the more extensive the rash is and the more of coalescence you have of the rash, the more severe the measles is. This is just a table or a graph showing you the clinical presentation. So they start with fever. The fever will intensify at the time that the rash comes and intensifies. When the rash comes, everything sort of intensifies, the fever, the conjunctivitis, the cold, and the cough, and then it gradually begins to decrease. By the time you get to the third day of the rash, your fever should start decreasing. You should start having low-grade temperatures. And if you don't, then you should worry about any kind of complications. And like I mentioned before, the cough can persist for 2 to 3 weeks after the illness itself, as long as it's just a cough and there's no fever associated with it. The child is still not unwell, still not irritable, still not having a headache, then that's okay. I mentioned about modified measles, so I'll talk about modified measles very briefly. In modified measles, it's an attenuated infection. It's not as severe as your classical measles presentation. The rash is not as intense. They might not be conjunctivitis. They're not highly infectious. And who gets modified measles? These are people that have some antibodies to measles, but the antibodies are not protective. So it can actually be in infants, although infants are the population where we can get severe measles, and we need to be very careful. But this population also can have the modified measles because most of the mothers will already be immunized. So mothers will have antibodies to measles. So you will get passive immunity, so passive transfer of the antibodies transplacentally to the babies. So they have a little bit of antibodies, but the antibodies are not protective enough for them not to get measles, so they can get a modified form of measles. Recipients of immunoglobulins, for any reasons, will also have the measles antibodies, so they can have modified measles. People that have been vaccinated can also have modified form of the measles, and very rarely people that already have a history of measles. Healthcare workers that have been vaccinated and household contacts can have breakthrough measles. So they will need to have been caring for the person and been in close contact with them. And the incubation period in this case is much longer. And also people with breakthrough measles are not as infectious because they already have the antibodies. They have neutralizing antibodies already in their respiratory mucosa. So they do not spread the infection as much as if they had primary measles. So we're going to talk about am I right to go ahead, talk about the complication of measles, or any questions before that? Is there any questions on that?
Nothing on Slido. Nothing in the chat.
Okay. So who gets complications of measles is usually people at the extremes of age. So our infants in terms of pediatrics and older people, pregnant women, immunocompromised individuals, and in low resource settings. And sometimes when I think about low resource settings, I'm aware that we are in Bradford, and should this be applied to us? I did speak to, there is a consultant infectious disease specialist in Leeds, Sean O'Riordan, when we had a case of measles, that should we be considering Bradford as maybe low resource, and should we be thinking of vitamin A? But at the moment, we are not. But individuals with vitamin A deficiency or poor nutritional status are at risk of having complications of measles. And people, in 30% of the cases of measles, they will have at least one or more complications of measles. So the first complication I'm going to talk about is about immune suppression. So measles itself causes a suppression of your immune system, and it causes the suppression of your immune system for quite a while. It can be up to 3 years. It causes an effect on your cellular as well as your humoral immunity. It causes immune defects with the T cells, causing depletion of T cells in your lymph nodes and in your spleen. And it decreases your pool of naive B cells, and it also decreases your memory B cells. So those antibodies that you had made to other viruses that they had come across previously, it decreases the number of those antibodies. So there is a study in PubMed, which was the long-term measles-induced immunomodulatory, increases the overall childhood infectious disease mortality. Immunosuppression after measles is known to predispose people to opportunistic infections for a period of several weeks to months. So again, vaccine comes into play, because if you're vaccinated from measles, then having all those other infections that you can get after getting measles, it also decreases. So it's about educating our family and advocating for our children in Leeds in Bradford regarding vaccination. So in terms of other complications, diarrhea, gastrointestinal complications. So you can have diarrhea with measles. So just letting the family know that your child can develop diarrhea, you know, telling them about the red flags for diarrhea. And diarrhea is the most common complication of measles. You can also have other gastrointestinal complications like gingival stomatitis. Obviously, if the child has gingival stomatitis, they might not want to eat, they might not want to drink, they might be dehydrated. So letting them know what point they should seek medical advice. You can have other complications like hepatitis, mesenteric lymphadenitis, appendicitis, in terms of gastrointestinal complications. Otitis media is also very common in 5 to 10% of the cases. So we can look out for otitis media, know that we can prescribe some antibiotics as normal for otitis media. Keratitis can also occur, which is a common cause of blindness, and other complications in the eyes like corneal ulcerations. You can also get cardiac complications like myocarditis. So if the patient's tachycardia is just more than you would expect for their high temperature, you know, that might be something that might alert you to maybe a myocarditis. They can have pericarditis as well. You have pulmonary complications. So you can have measles causing pneumonia. So this is the most common measles associated death in children. So I mentioned that, you know, after the measles, children can continue to cough for 2 to 3 weeks. But if they continue to cough and they still have a high temperature after 3 days of the rash, then this might alert you to maybe this is a pneumonia. Maybe we need to be treating for co-infection or discussing with the hospital. Measles can also cause croup. So you know, they can have barking cough like they would, you know, and it's the same as any other croup. We look for the same things in terms of the work of breathing, and we give the same things in terms of dexamethasone that we would give for croup. It can cause bronchiolitis, and it can also cause bronchiectasis. So this is recurrent pulmonary infections for a long time. So again, the vaccination comes into play, because if you get bronchiectasis, it increases morbidity for a long time. You can have bacterial superimposed infections causing pneumonia. So you can have staph aureus causing infection, streptococcus pneumonia, streptococcus pyogenes, Haemophilus influenza, which is another one that we vaccinate for. So you need to be asking about the vaccination status of this patient. And knowing that we can have bacterial superimposed infection with measles, usually in the community, you give amoxicillin for, you know, for chest infection. But with measles, and if you're worried about a chest infection with measles, we might want to broaden the spectrum and give co-amoxiclav and have a very low threshold to discuss with the hospital and signpost the patient for any red flags. And also you can have co-infection with other viruses. So measles virus, you can have co-infection with parainfluenza, flu, RSV virus, enterovirus as well. So I'm going to go on to neurological complications if there are no questions at the moment.
Oh, I've posted a question. I was just trying out Slido. I was just wondering, Zainab, is there any case to vaccinate an unvaccinated individual after they've had a confirmed case of measles infection?
Vaccinate an unvaccinated individual. So we definitely want to vaccinate people. And we know that once you've gotten measles, your chance of getting measles again is very low. So you do have immunity to measles. And I have to say, while I read about a vaccinated contacts, I haven't seen anything about vaccinating a person that has gotten measles. And
I guess there wouldn't be any harm in doing it, would there?
There wouldn't be any harm, but then will you mount an immune response? Because when you have gotten vaccinated, then you develop antibodies. And then when I give you the vaccine, because of those antibodies, you're not going to mount an immune response to the vaccine. It will probably not make sense to vaccinate them. Yeah.
Okay. And then I just had another question about the ocular complications and the cardiac, do you know, is there a particular time frame when they tend to appear?
So the cardiac complication actually can occur when you have your when you have the exanthem with a rash. So with the acute measles infection, not necessarily when you are recovering from the infection. So about a particular time frame, it can occur during the recovery period, it can occur during the acute period. So there's no particular time frame. You need to just be aware that this can be a complication and look at things. Yeah.
And the keratitis, that is different. That's pain. Excuse my my knowledge of keratitis at ages since I've seen it, but that's a sort of painful condition, isn't it? And causes a red eye, different to the conjunctivitis.
It causes a red eye. It causes dryness of the eye. Yes, so I guess you would be thinking about it in the case of when the red eye that you're seeing, it's just more than you expect to see. The photophobia is just a little bit more than you expect to see, and is just having a high index of suspicion.
Yeah, more severe than.
And the red eye not getting better in the time that you think that it should be getting better. So, for example, after the rash appears, the symptoms start to get better. They start to decline, but no, the red eye is persistent and still painful and still watery.
Yeah, that's helpful. Thanks.
I was going to say, the kids look, I suppose, they can't even keep their eyes open or one of their eyes open. They would struggle, they would cry more.
Yeah.
Whilst in measles, it doesn't hurt. They just feel rotten.
They just feel rotten, and there's not necessarily that much photophobia, although there's lacrimation. Yeah. So neurological complications. So the encephalitis can occur during the acute phase of the measles. It says 1 in 1,000 of measles cases can have encephalitis. But if you think about the susceptible population, where one person can infect 15 to 20 people, then it doesn't take long to get that one case of encephalitis. So the encephalitis will usually occur within a few days of the rash. And what are we looking for in encephalitis? So the child is miserable anyway. They have a headache anyway. They don't want you anywhere near them. So it's also, again, having that high index of suspicion. This child just looking a little bit more miserable than you would expect when you're trying to turn their head, or they're keeping very still, not wanting to turn their head to the side. So I tell you about neck stiffness. They're very irritable. They're irritable anyway, but just more irritable than you would expect. So it's knowing that you can get encephalitis with measles, keeping it at the back of your mind and looking out for it, because with measles itself, you could miss it. Encephalitis can be fatal in 15% of the case, so it's important to be aware that this is a complication of measles. So we have other neurological complications like acute disseminating encephalomyelitis. It occurs again in 1 in 1,000 cases of measles, but usually it's found in the recovery phase. So when the child is already beginning to get better. It's a post-infectious immune response. And what do we see in this case? We see things like, headache again. We can see convulsions, headache, meningeal irritability. We see signs of myelitis. So there can be paraplegia, quadriplegia. There can be back pain. There can be loss of bladder or bowel control, sensory loss. So that would tell us about ADEM. And of course, these children need to be referred to the hospital. Another important complication, neurological complication, is the subacute sclerosing panencephalitis, SSPE. What's important to know about this is that the younger the person is when they get measles, the more chance they have of getting SSPE. So that's why it's important, again, vaccination, and to identify contacts in the household. So if there was a child in the house who is 6 months of age or less than 6 months, they should come to the hospital to get immunoglobulin. If they're greater than 6 months, they should get MMR vaccination as soon as possible. So this is a progressive neurological condition that leads to death. It has different stages, but I didn't think it was important to talk about the different stages. It causes seizures, and it causes a coma, convulsions, myoclonus, and it eventually leads to death. And children who have gotten this infection at less than 1 year of age are more prone to get SSPE, and it's usually 7 to 10 years after they have gotten a natural measles virus infection.
Zainab, just to draw everyone's attention on West Yorkshire Healthier Together, which Nicole is on the call, I think, has done. On their measles page, there's 2 little video case studies, and one of them is SSPE, and it's absolutely terrifying. It's worth watching. So it's a girl who got measles, mild measles infection as a baby, went through school, went to university, was perfectly healthy, and then in her early 20s developed this devastating progressive neurological deterioration. It's really scary. So just if you had any parent who was still had any doubt, it might be something to sort of direct them to the West Yorkshire Healthier Together page, because it's such a strong case to have the vaccine.
It is. So I put this here, and this is from the UK Health Security Agency, and I think it has been sent round to all the GP surgeries. So it's just basically what to do when a patient comes to you in terms of infection control. When a patient comes with rash, cough, conjunctivitis, coryza, and you're thinking that this may be measles. So it's very important that the receptionists are aware that a patient with fever, rash, cough, coryza might be contagious, and that if they're coming through, like I said, they should be put in an isolation room or go directly into the GP's room, and the GP should be aware, to put on the FFP mask, FFP3 mask as well. When they're being triaged, we want to find out, are they unvaccinated? Are they partially vaccinated? Have they traveled to an area where measles is circulating, but then we are in an area where measles is circulating at the moment? Have they been in contact with a confirmed or suspected case of measles? If they need to be seen in person, like I said, they should go straight to the consultation room on arrival. When the patient is being seen by the GP, I guess it's 2 things that you want to do. First of all, you want to know, am I referring this patient to secondary care? Based on, are they working really hard to breathe? Is their oxygen saturation low? Do they look like they have neurological complication? Do they look like they have severe pneumonia? And is this child less than 6 months of age or less than 12 months of age? Do they look like they have severe illness with really intense rash? In this case, we might want to refer them to secondary care. But when you do refer them to secondary care, it's very important that you contact the A&E and contact the hospital and let them know, so that we can triage them appropriately and put them in an isolation room or in a negative pressure room. If you are going to discharge this patient home, it's very important to know about household contacts. And also to let them know that they're infectious from 4 days before the rash appears to 4 days after the rash has appeared. So they should stay away from nursery education settings or work. Let them know. Sorry.
Yeah, he's joined and has
they should stay away from nursery education settings until 4 days after the rash has disappeared. Let them know about red flags to look out for. So things like if the fever is persistent for more than 3 days after the rash has appeared and you're still having high fever, if the child is still having headache, still having vomiting, develops new symptoms like backache, begins to be more lethargic after they had been lethargic before and recovered, things like that. So alert them to the red flag of when to seek medical advice. And it says, as soon as you have discharged that patient home, within 24 hours, you should have in all the GP surgeries a number to call your health protection team, because then they will go to the home and do contact tracing. So for diagnosis of measles, you need to have a high index of suspicion, which we do now because we do know that we have outbreak of measles. We need to take a thorough history, including vaccination history. We need to look out for the clinical findings that we have discussed, and we need to know about the household contacts. Are there pregnant women at home, immunocompromised people at home, children less than 12 months old at home, because then they will need post-exposure prophylaxis. From looking at the last slide, I don't think that in GP surgeries you do any swab. I think that you call the health protection team and they go to the home and they collect the oral fluid. I just thought I'd mention about the swabs because we do it in hospital. So in hospital, we will do a mouth or throat swab. We will take the swab along the gum line and over the tongue. And we do this within 6 days of onset of the rash. And what we're looking for in the swab, so we send it off and they do PCR for the RNA virus. So we detect the presence of the virus in the swab. We can also take some blood and looking for IgM to check the immune status of a contact. We can also check for IgG, but the IgG comes later, and so it might be falsely negative. And when the health surveillance team go to the home, they take oral fluid. And the oral fluid is quite useful because it tests for the PCR for the virus, and it can also check for IgG and IgM as well.
Zainab, does it take a few days to get the PCR result back?
It does take a few days to get the PCR result back. So that's why it's important that we have this high index of suspicion, look for Koplik spots, look for signs that this might be measles. And before we get the PCR back, we need to start isolation and identifying those people that might need post-exposure prophylaxis, because it's better to give it rather than not in that case. I just thought I would go through a few differential diagnoses. So the first ones are the viral infections associated with rash. So we have rubella, which is associated with the rash, but children with rubella are usually not as unwell as the children with measles, unless you see the modified measles, of course. It can be erythema infectiosum, which is the 5th disease, and we know that you get the rash mostly like a slapped cheeks appearance, and usually by the time the rash comes, the fever has subsided, so that might tell you also that this is not measles. We can have the human herpes virus 6, which is really very hard to differentiate from measles. I think we have one in the ward, which was thought to be Kawasaki as well. And the rash spreads in this case, in human herpes virus 6, it spreads from the trunk to the face rather than from top to down. So that might help with differentiation. Of course, you have infectious mononucleosis, where you can have pharyngitis, you can have fever, lymphadenopathy, and you can have a rash following ampicillin ingestion. So it's important to ask about any drugs or medications that they have taken. We won't really go into HIV infection. But then it's important to know about the bacterial infections of the rash, because obviously those need to be treated with antibiotics. So scarlet fever can present the same way, but we know that scarlet fever has the classic sandpaper type rash. They can have the strawberry tongue, the pharyngitis, it's a blanching erythematous rash. So for those ones, we know to give antibiotics, because for measles, we don't give antibiotics. It can be a mycoplasma infection as well. And we need to also think about other rheumatological conditions, like juvenile idiopathic arthritis can come out in a salmon pink maculopapular rash, but they usually have joint involvement, which measles doesn't have. And you also need to think about acute cutaneous lupus as well. I put a slide for Kawasaki by itself, just because it's really important, isn't it? Because with the measles case that is not severely unwell, you're gonna send them home, and you're gonna do contact tracing, and you're gonna alert the health protection team. But you don't want to do that for Kawasaki, obviously, because it has implications to the heart. You can have cardiac problems, and you can have coronary artery problems. So it's just to looking quickly at Kawasaki. So Kawasaki, we need to have fever lasting for at least 5 days, which we know that we have in measles as well. We have bilateral bulbar conjunctival injection, which is also non-purulent, like measles is non-purulent. But in Kawasaki, we also have oral mucous membrane changes. So we have the fissured lips, we can have the injected pharynx, we have the strawberry tongue, which you don't necessarily have in measles. Obviously, we will not have any Koplik spots. In measles, usually the palms and the soles are spared, but in Kawasaki, you can have peripheral extremity changes. So you can have edema of your hands and feet, you can have erythema of your palms and soles, and you can have periungual desquamation in the convalescent phase. You have a polymorphous rash in Kawasaki, and which can resemble a rash that you find in measles as well. And you can have a cervical lymphadenopathy with one lymph node measuring at least 1.5 centimeters. If you're having big lymph nodes, extremity changes, fever for at least 5 days, in this case, we should be thinking, could this be Kawasaki rather than measles? And we should be discussing with the hospitals, because they will need to come in for immunoglobulin and an aspirin and an echo for Kawasaki. So what is the treatment of measles? When you send patients home that are well enough to go home, along with advice of isolation and contact tracing and calling the health protection team, we need to give advice regarding antipyretics. So they can have paracetamol, they can have brufen. We need to make sure that they remain well hydrated at home. You need to tell them about, the mucus, they can get the mucositis, gingival stomatitis. So if they're not drinking enough, and the signs of dehydration, and when to seek medical advice. And we might need to treat superimposed bacterial infections. So to keep in mind that they can get otitis media, so look out for the otitis media in the surgery and treat that if necessary. They might have a mild bacterial co-infection of their chest, so we can treat that with a more broad spectrum antibiotics. But other complications like seizures, respiratory failure will be treated in the hospital. So vitamin A deficiency. Vitamin A deficiency can result in delayed recovery and increased risk of complications. And this is usually found in resource-poor settings. Measles itself can cause a decrease in vitamin A. So the WHO have recommended that everybody in every country with measles should get vitamin A deficiency, but we are not currently doing that in the UK. And the CDC have recommended that under 12 months of age, admitted to the hospital with severe measles should get vitamin A. Ribavirin is an antiviral, which is used to treat severe measles infection in children who are less than 12 months of age with severe measles and pneumonia, or greater than 12 months of age with measles pneumonia needing ventilatory support, but this will be discussed with the tertiary center, even if we get them in the hospital. I wanted to talk about post-exposure prophylaxis before we finish. So the best way to achieve protection and to achieve measles elimination is high vaccine coverage with 2 doses of MMR vaccine. In order to give post-exposure prophylaxis, we should identify contact within the infectious period. So if you get in contact with the index case within the infectious period is 4 days before the rash and 4 days after the rash. When they're household contact, we say that the date of exposure is the date that the rash first appears. And when they're non-household contact, we say that the date of exposure is the last day they were exposed to the person while they were in their infectious phase. So we give post-exposure prophylaxis to immunocompetent vulnerable infants. In infants under 6 months of age, we give human immunoglobulin, ideally within 72 hours, but we can give it for up to 6 days. The reason why we give the immunoglobulin and not the vaccine is because we still have the maternal antibodies. So if you have the maternal antibodies, they will not let the child mount an appropriate immune response to the vaccine. So they need to come into hospital to get the human normal immunoglobulin. I did read in the website for UKHSA that you should be able to give IM immunoglobulin in the community, but that's not being done. They're coming into hospital and getting the IV immunoglobulin. In infants who are between the age of 6 months to 8 months, it depends on who the index case was. If the index case was a household contact, we assume that because it's a household contact, there's very much contact between them. There's a high viral load. The child has more chance of getting infected and more chance of getting a severe infection. So if they are household contact, they should ideally, between the age of 6 to 8 months, come into hospital for IV immunoglobulin within 72 hours or up to 6 days after the rash first appeared on the index case. But if the exposure was outside of the household, then we can administer in the community MMR, ideally within 72 hours. In infants who are 9 months old or older that have been exposed, we administer the MMR vaccine, ideally within 72 hours of exposure. It's just to be aware that just because we administered an MMR vaccine does not mean that that child has had their first dose, because in less than 12 months of age, we assume that there's still some form of maternal antibody. So the child may not be able to mount a very adequate immune response to the MMR vaccine. So any child that has received MMR vaccine before 12 months old, we assume that they have not had their vaccination. And when they get to the age of 12 months, we vaccinate them as we would in terms of the national schedule for vaccination. But also to be aware that if a child between the age of 6 to 8 months has had immunoglobulin because he had household contact exposure, we vaccinate them 6 months after the immunoglobulin. We'll have to wait longer to vaccinate them so that the antibodies can leave the bloodstream. This is just a graph showing you how lovely it was when we had a good, when vaccine was introduced for measles. So starting in 1980, we had about 4.5 million cases of measles worldwide, and all the way to 2009, where we had less than 500,000 cases of measles due to the global immunization program and vaccine coverage. So this shows you that the vaccine does work, and it's our job as healthcare professionals to educate our families in Bradford and advocate for the children in Bradford as well. And I think that is all from me. Thank you very much.
That was brilliant. Thank you, Zainab. I've learnt loads. I've just got a couple, just to remind people, if anyone's not too hot on how to notify our health protection team. Can you see that? Yeah, that's just to show that we do have the number in Bradford in GP Assist. We've got a link, but measles we do have to notify urgently, so they want us to telephone through the cases within 24 hours. And in addition to email the registered medical practitioner notification form, that's the email address there. But the form is in Assist. So in Assist in infectious diseases, then over here on the right, notify, and there's the phone number there for the local PHE team or health protection team as they're now called. And then that opens up notify, and it brings up the pre-populated form with the email address.